Condition, just to give you an idea, an update as to where we are in diabetes in 2017, and particularly how it relates to us in Guam, in the Western Pacific, and the problems that we have, both with the population that we're dealing with, and also the economics and the kinds of therapy that we have at our disposal, both of which are, I'm sure you all know, are significant problems. So one of the things that I want to touch on was, go back, go forward. I don't know how to get rid of that. Okay. So the first thing that I want to talk about is there a worldwide epidemic in diabetes? And I think most of us know that there is, and then talk about how that impacts in the United States and us out in the Western Pacific. And then more specifically, what are the racial differences among patients with diabetes? And we're going to focus pretty much on type 2 diabetes, which, as you know, is preceded by something called the Metabolic Syndrome, and we're going to go over what the Metabolic Syndrome is and how that impacts us here in the Western Pacific, and how that's become extremely important to the American healthcare powers that be. Then we're going to try to determine whether the outcomes that we're looking for in diabetes, which are predominantly improved macrovascular outcomes, less heart attacks, strokes, and amputations, less renal disease, less blindness, whether all these things are a function of the path that we take. Is it important what drugs we use and how we use them? And then the next to last thing we want to know is, here in the Western Pacific and in the States, how tight does our control have to be in order to get the kinds of impacts that we want? And then finally, in our population, what kinds of therapies would be optimal? Okay. So that's a pretty hefty agenda. And if you have any questions, you can please feel free to interrupt me at any point in time if you like, or you can save them at the end. I'll be glad to go over any of the questions that you have at the end. So the next issue is there a diabetes epidemic in the world? There's a slide from the Hindustan Times, and in a country that's not too far away from us, stating that this is now impacting the urban poor, and India needs urgent prevention and screening. And this is something obviously that applies to us here as well. But what about in the United States? Well, here's something taken from a leading journal of environmental health and safety, and I focus your attention on the headline here, which states that the CDC believes that there's more than 100 million U.S. adults with diabetes. 100 million, in a population of a little over 300 million. Okay. Well, let's break that down a little bit further. Is that really true? Well, it turns out that it's not really true. But this is really when they're considering this kind of person, it's probably more true. Here's a hazardous waste.
Hazardous waste.
I think you'll all agree it's a horizontally challenging condition. Okay, so here's the diabetes epidemic in the U.S. It's estimated that 23.1 million people in the U.S. really have diabetes. 95% will have type 2 diabetes. 5% will have type 1. But if you look over here at the arrows, most of this diabetes is in the American Indians, the Alaska Natives, the Asiatic population. And we're going to talk about insulin resistance. The highest insulin resistance in the world is found not in the United States, not in the American Indians or the Alaskan Indians, but right here in the Southwest Pacific, a little island called Nauru has the highest insulin resistance on the planet, not too far from where we are. at this point in time. But the prevalence, the point that I want to raise here is the prevalence of diabetes is highest among the Asiatic Indian population. I think I gotta shrink this down before I can move on. Okay. Now we're going to talk about the metabolic syndrome, which is that it's pretty much characterized by centripetal obesity, that horizontally challenging condition that you saw the picture of before. It's associated with increased blood pressure. It's associated with increased triglycerides, very low HDLs, elevated uric acid, and a high incidence rate of type 2 diabetes. 33.9% of the U.S. adults, that's where the third of the U.S. population comes in. The CDC has estimated diabetes and really included in its conception of diabetes this notion of impaired glucose tolerance and metabolic syndrome. And here's where we have 84.1 million people with that metabolic syndrome in the States. And you can see the percentage, 33%. 11% who don't know that they have it. Now, how do they know? This is a more difficult disease to determine. You have to see that they have impaired glucose tolerance. How can you determine that only 1 in 10 people with impaired glucose tolerance know that they have impaired glucose tolerance? Well, it turns out when you do a census, you can do a random sampling of their glucose tolerance in a patient population that will give you a statistically significant result. And of all the people that they sampled who had impaired glucose tolerance, 10%, or only 10%, knew that they had it. The 90% who had impaired glucose tolerance in that random sampling did not know that they had impaired glucose tolerance, as opposed to diabetes type 2, where half the population who had overt type 2 diabetes knew that they had type 2 diabetes, but the other half had no idea. And that's how the American Diabetes Association and other organizations have instituted programs to find the missing 50% of folks. It's through this random glucose tolerance test. Aggie?
Are you using pre-diabetes synonymously with impaired glucose tolerance?
Yeah, that's a good point. I'm using pre-diabetes here synonymously with both impaired glucose tolerance and impaired fasting glucose. So both of those things. And just to try to lump them together, if you just consider a hemoglobin A1C from the 5.6 to 6.4 range, you can consider it that way. But it really comprises both impaired glucose tolerance as well as impaired fasting glucose, which are really two different kinds of pathophysiologic syndromes, of which probably the more important one is impaired glucose tolerance, but we'll talk about that in great detail a little later on. Okay. Diabetes complications is something that we all pretty much know: smoking, overweight, obesity, physical inactivity, hypertension, high cholesterol, hyperlipidemia, and elevated glucose. Of all of these, only the high glucose has really no impact at all in terms of being a modifiable risk factor. All of these other ones are modifiable. You affect these, you're going to affect the macrovascular outcomes, heart attacks, strokes. But sugar, no.
Oh, gosh.
Okay, so let's talk about what it is that we're going to be talking about. And here's a little cartoon to kind of give you an overall idea of how diabetes plays out. And I'm going to show you essentially the life direction of how people with diabetes tend to manifest their syndromes. But it's a combination of both genetics, and the concordance rate among twins is about 95%. So if you're obese and you're overweight, and you have a twin with type 2 diabetes, you have a 95% chance of developing type 2 diabetes in that same year. So it's a genetic predisposition which is very strong, but also lifestyle contributes in terms of stress, being overweight, smoking. The first thing that happens, and I'll show you that in the next slide, is the metabolic syndrome. And that's associated with polycystic ovary syndrome, with women with increased central obesity, troubles menstruating, increased hairiness, masculinity, obesity. Psoriasis is very prevalent in these islands and is another risk factor for type 2 diabetes. Acanthosis nigricans is also very prevalent on these islands and is also a risk factor for the metabolic syndrome. And association with increased levels of inflammatory cytokines like TNF-alpha. Now the interesting thing is, as you saw, 83 million Americans, maybe 100 million Americans with metabolic syndrome, not all of whom, 23 million Americans, go on to develop type 2 diabetes. But the rest go on to develop microvascular disease without diabetes. Just another indication that it's not the sugar that's contributing to this. But type 2 diabetics as well have macrovascular disease as well as microvascular disease. The macrovascular disease, heart attacks, strokes, amputations. The microvascular disease, retinopathy, nephropathy, and neuropathy. These are the disorders that are associated with and are modifiable risk factors for glucose. You can control glucose and you can impact on the microvascular disease. Unfortunately, you do not impact on the macrovascular disease. Okay, what's the natural history that I was talking about before? This part that Aggie was talking about, that I was talking about, and we're all talking about in terms of the metabolic syndrome is all the way to the left of this particular line. So if you look at what happens to glucose, glucose starts out, and whether it's postprandial or fasting stays pretty much normal. The first thing that happens is that the postprandial glucose goes up, and then you'll see the fasting glucose start its rise, but later on in the course of the disease. Now what's happening pathophysiologically is initially that insulin resistance has become overweight. Insulin resistance increases. The predisposition for diabetes obviously increases. But of all the people who have this particular syndrome of prediabetes, it's only those whose beta cells begin to fail that go on to develop type 2 diabetes. And those whose beta cells are intact do not have elevations in their glucose. They just go on to develop the metabolic syndrome and the macrovascular complications thereof. So just keep this in mind, that even before overt diabetes, that insulin resistance comes into fore. There's the first defect is something called first phase insulin release, and that impacts impaired glucose tolerance. And then the next thing that happens is that the fasting glucose goes up. Fasting levels of insulin start to decrease. Here's a curve that shows you what the first phase insulin response looks like. It's in response to a glucose load, in this case an IV glucose load. Load is given here. The first phase insulin response takes over about 10 minutes, give or take a couple of minutes, and then there's a second phase. It's this particular phase that is the first thing that goes in people with both impaired glucose tolerance and type 2 diabetes, after they have the impaired glucose tolerance.
Doctor, I have a quick question. When you said some of them, back to your previous slide talking about people with metabolic syndrome, some go on to develop type 2, while others don't, but they do develop macrovascular disease. And yeah, so with strict glucose control, microvascular complications are abated, but are managed. But
Not
so
the macrovascular.
What should be done to on that side, the macrovascular disease, you have to be more aggressive about decreasing
Yeah, we're going to talk about that.
Oh.
Probably the most important two things to try to decrease are weight and stress. Okay, and the agents that we use, and that's part we're going to talk about later, need to be agents that don't increase your weight, but rather agents that decrease your weight and help you to lose weight. Unfortunately, as you'll find out, we don't have the funds for most of the people that need these kinds of drugs. That's difficult. And That's what we're all going to have to work together to try to figure out how we can get access to the drugs that we really need to get the maximum benefit in our patient population. That's what this talk is really ultimately all about. You had a question?
Yeah, well, I think there is a correlation between the sugar that you take, even for people that are not in the type 2 diabetes, because eventually sugar will become into adipose tissue, right? So in the United States, listening to an expert, it's in pediatrics, I'm in pediatrics, the consumption of sugar is huge. It has increased dramatically from, in the last like 100 years, people used to consume, let's say a pound or two in a year, now to, I can't remember, but it was a huge amount. And so, yeah, exactly. Because we consume so much sugar. So both are related, but maybe you'll get to that.
Yeah, but there's really got to, in order to get diabetes, you have to have two things. Not only the insulin resistance, but you also have to have beta cell failure. Just consuming a lot of sugar is not going to get you to diabetes. You have to have the genetic abnormality.
No, what I'm getting at is that the consumption of too much sugar will lead to obesity.
Absolutely right. Absolutely right. No question about it. Okay, so here's what this looks like in a cartoon fashion. Here's actual data that shows you the first phase insulin response to a 20-gram glucose pulse. And these are in normal individuals. And this is what it looks like in patients who have type 2 diabetes. You see they've lost this first phase insulin response. Okay, now to see if you've really been listening to what I've been talking about here. This is a study that was actually done by Dr. Peter Bennett at the Gila River Foundation of Pima Indians in Arizona. What they wanted to know is who goes on to develop type 2 diabetes of people with impaired glucose tolerance. I alluded to that a little bit before in the cartoon that I drew. So here's a depiction of patients that were at high risk for developing type 2 diabetes. These are on the bottom, this is relative fasting insulinemia. This is the amounts of insulin that are present before eating under fasting conditions. And these are the people in the half that had the highest fasting insulin. These are just the half that had the lowest fasting insulin. Whereas going up and down, this is the first phase insulin response, and this is the relative first phase insulin response. These are good first phase insulin responses. These are bad insulin responses. So of these quartiles, call it A, B, C, and D, red, yellow, green, and crosses. Who goes on to develop type 2 diabetes? How many of you think it's this quadrant here called A? Those with the highest levels of first phase insulin responses and the lowest levels of fasting insulinemia go on to develop type 2 diabetes. How about over here, B, which is they have the highest first phase insulin response and the highest levels of fasting insulinemia. How about over here, C? These have the highest fasting insulin levels and the lowest levels of first phase insulin responses. That's C. How about D? The lowest levels of insulin fasting and the lowest first phase insulin responses. How many of you think this group over here? Okay, I got 4 of you. How many of you think this group over here?
I think it's the highest.
How many of you think this group over here?
You've got to think about this first, Dr. Fast.
Okay, how many of you think over here? Okay, well the answer is
The first phase, the lowest.
C. These people fail their first, remember they lose their first phase insulin response, so that's gone. But in order to maintain their fasting sugars, they're putting out maximal amounts of insulin to keep their fasting sugars under control. And it's this group that goes on to develop type 2 diabetes. Highest levels of fasting insulin and the loss of the first phase insulin response. Okay, now let's talk about the different kinds of populations that we have, particularly as it affects us in the Western Pacific. You can see what I've highlighted. Here, Paulies like me, And you can see that basically we get diagnosed fairly early. We have mostly macrovascular complications, very few microvascular complications, and maybe we're caught 1 or 2 years after the diagnosis. And it's not necessarily that aggressive a disease. Orientals can be somewhat in the middle, although they're very refractory. They don't like coming in and seeing doctors. And so they come in fairly late, and maybe 5 to 10 years after the diagnosis. They have a high incidence of both micro and microvascular disease. The Hispanic population is probably in between the U.S. black population and the alley, but also significant microvascular, macrovascular disease. They take a little bit longer for them to be diagnosed. The A1Cs are a little bit higher when they're seen, and it's a more aggressive phenomenon. The U.S. blacks are significantly aggressive. Their A1Cs, when they're seen, are a little higher. They have diabetes for a little bit longer, and that's a significantly aggressive disease. But us, as you can see, we've got the worst of all worlds. We've got significant microvascular disease, significant macrovascular disease. The A1Cs, when most of us get to see these folks, are just 14. Yeah. Years before they're diagnosed, a lot of them will tell me that they've just had it 5 years ago. It's hard to believe that they're in florid kidney failure and about to lose a limb when they've only had the disease for 5, unless it's just extremely progressive. And those are things that we need to know more about. Once we have better data, which is one of the things that we're going to talk about at the end, some way of getting better data, we're going to be able to sort this out. And until then, we're really kind of in a little bit of a gray zone. Okay. I want to emphasize, because this hasn't been really emphasized that much, what major players there are in diabetes. Most people talk about the liver, the fat cells, the muscle cells, but really the most important organ, I think, is the kidney. And there is particularly think about the islanders that we have here in the Western Pacific. Being on an island, you don't know where your next meal necessarily is going to come from. I'm talking about the folks that settled here years ago. You don't know where your next salt may come from. So it behooves you to be able to kind of hold on to salt and water. And salt and water, as you know, play a major role in hypertension. And hypertension plays a major role in kidney failure. And so this glucose transporter, if it is increased in activity, will hold on to both glucose and salt. And the reason I mention this and think it's so important is that if you look at patients when they go into kidney failure, their insulin resistance goes away. They become much more insulin sensitive when they're on dialysis. Why is that? Well, that's probably because gluconeogenesis, which occurs very significantly in the kidneys, and this glucose sodium copant transporter are all downregulated, are all not as hyperfunctional. There's also the problem of hyperfiltration. So folks here tend to filter very large amounts of plasma volume excessively because of being overweight. And then as more glucose gets reabsorbed, as more salt gets reabsorbed, the glucose values go up and individuals become hypertensive, and it becomes more difficult to excrete a salt load when you eat salt. So the kidney is an extremely important organ here, not given as much relevance as it really should be required. And the next item on the agenda is really to discuss what agents we should be using. What are the two most common agents we use to treat patients with type 2 diabetes? Metformin and glipizide. Glipizide, glyburide. Some patients, if they have insurance, may be on glimepiride. But those are called sulfonylureas. Okay? Let me tell you how these sulfonylureas act. They act upon what's called ATP-sensitive potassium channels. So what happens is, as your glucose levels go up, ATP level, which is the major currency of fuel, it's metabolized in the mitochondria. The ATP levels go up, and the ATP binds to this sodium, to this potassium-dependent ATP channel, ATP K channel. And what happens is it closes it. And when it closes, I'll show you a cartoon. When it closes this K ATP channel, the cell depolarizes, the beta cell depolarizes, calcium influxes, and insulin is released. All because glucose is going up, ATP is going up, and these K ATP channels close. When you take a sulfonylurea, you mimic the effects of ATP. So you're giving an agent that acts like ATP, and you're closing these ATP-sensitive potassium channels. But the problem is that these ATP-sensitive potassium channels also exist in the heart. And they're the major mechanism for what we call the vasodilatory response to ischemia. So if a part of the heart isn't getting enough oxygen, ATP levels fall, metabolism falls, and these K ATP channels open. And as a result of them opening, there's vasodilatation and more blood flow to the areas that are not getting enough blood flow. What happens when glucose goes up? Well, as glucose goes up in the myocardium, it causes more ATP and closes these ATP channels. So that's one of the reasons why diabetics have a high incidence of cardiac failure. But what happens when the glucose goes up and you're dumping in more sulfonylureas? Well, you're closing these ATP-sensitive potassium channels. This is the cartoon. The increased glucose closes these channels, insulin is released. When it's open the other way in the heart, there's vasodilatation. And there are drugs which are just the opposite of sulfonylureas. Drugs like diazoxide. These are K ATP channel openers, and they cause, people that tend to treat folks with hypertension, they can cause a significant and immediate reduction in blood pressure. So just think about it. One of the two most common drugs that we use to treat diabetes has a significant impact on the ability of the heart to respond to areas that are not getting enough oxygen. And if you have the metabolic syndrome and you have atherosclerosis and inflammatory processes throughout your arteries, is this something that you really want to give to patients, your father, your mother, your grandmother, your sisters, your brothers who have this disorder? Think about that. Okay, this is a large cohort study to look at glucose-lowering agents. Only metformin itself as a monotherapy was not associated with increased 5-year mortality compared to matched controls. Individuals on a combination of sulfonylurea and insulin had the highest mortality risk. This is another study. This is a meta-analysis of sulfonylureas. At lower doses, sulfonylureas may not be that bad. So at extremely low doses, here's 3 trials that were done in England and Sweden, and there's clearly showed a benefit to being on tolbutamide, whereas in the UGDP trial where they used a high fixed dose of sulfonylureas, tolbutamide, there was significantly increased mortality. In the UK PDS, they randomized individuals to metformin. This was what I call a low hypoglycemic strategy. They weren't trying to get the blood sugars down to normal. They just wanted to impact on insulin resistance. And you see that any diabetes-related endpoint, diabetes-related deaths, all-cause mortality, and myocardial infarctions, all were statistically significantly better when you were on metformin. Here's total and cardiovascular mortality in the UK PDS low hypoglycemic strategy. Another way just looked at mortality. 53 deaths on conventional therapy. On metformin, only 26. So, just to show you how smart we are, the people who did the UK PDS trial said, oh, we know, and I'll show you a slide that says that the higher the A1Cs, the more people are going to die from their cardiovascular disease. So we know that lowering the blood sugar is going to make things a lot better. So they said if your sugar gets to 106 in this study, we're going to add, and you're on sulfonylurea, we're going to add metformin. And we're going to see what the impact is. So patients predominantly randomized to intensive therapy with sulfonylureas were not given additional metformin until their fasting glucose was 15, which, as I say, is about 106, 108. In view of the progressive hyperglycemia in these patients, protocol modification was to secondarily randomize. So this was a prospective randomized trial to see the impact of making the tightness of control even tighter. So this is a high hypoglycemic strategy. Now what happens when you tightly control? Well, as most of us know, the lower we want to get the A1Cs, the more frequently individuals will get severe hypoglycemic reactions. We know that, and we're concerned about that. So what happened when we tried to do this in this prospective randomized trial? Well, if you were just on sulfonylureas alone, you had 13 cardiovascular deaths. What you allowed metformin to be added when your sugar got to 106, 108, you statistically significantly increased that. And this is a small trial. So if you know anything about statistics, if you have a small trial looking at death that shows a statistically significant result, you better pay attention to it. So this is something about the combination of metformin and sulfonylureas, which is the most common combination that we use on Guam today, associated with a statistically significant increase in deaths. So here is the high hypoglycemic strategy looked at. And you can see that just diabetes-related deaths and all-cause mortality favored not being on that combination. Does paying attention to this hypoglycemic strategy make any difference? Well, here's just, I wanted to give you several different studies that looked at meta-analysis. So stratum 1 was treat to avoid hypoglycemia. Stratum 2 was treat to achieve even tighter control. And you can see in every instance, mortality, cardiovascular and total mortality favored the avoid hypoglycemia, not the tight control. Are there any treatment by strategy interactions? Yes, there was excess mortality, excess total mortality, and excess all-cause mortality in the high hypoglycemic strategies as opposed to the low hypoglycemic strategy. And here's another cartoon which shows you that it's much better to be on a low hypoglycemic strategy than in a high hypoglycemic strategy in terms of your ability to survive. Here's the slide I alluded to before about there's a high linear association. The higher your A1Cs, the higher your risk of death. The only problem is, as I mentioned, we tried 5 major trials to see if lowering this can reduce the death, and it doesn't. As a matter of fact, I'll show you another study where we even got a completely worse outcome. Well, it took the brains at the NIH, who are very, very bright people, who spent all their money looking at every inch of the insulin receptor until 1999, where Jocelyn had published several reports that say diabetics die of cardiovascular disease. Well, finally, in 1999, the NIDDK, NHLBI all decided, hey, guess what? There's a lot of diabetics who die of cardiovascular disease. Maybe we ought to pay attention to it. And they did. They did this ACCORD trial because the UGP trial didn't show anything, the UKPDS trial didn't show anything, but they said, well, maybe we didn't try to lower the blood sugars low enough. Maybe if we really try to lower the blood sugars low enough, we can get an impact. So how low did they try to do it? They were assigned intensive therapy to get the hemoglobin A1C below 6. They didn't really get there, but that was the strategy, the high hypoglycemic strategy. Well, what would you think, based on the slides that I showed you before, were going to happen to somebody when they did this? Exactly. They had increased death rates and they had to stop the study because people were dying at a higher clip. High hypoglycemic strategy is definitely risky in dealing with this patient population. Okay. We talked about the metabolic syndrome. It's very difficult to diagnose. It's expensive to try to get a hold of, but these are the people. We're looking at, when we look at diabetics, we're looking at the tip of the iceberg. It's all of us that are overweight, walking around with spare tires, that are really the individuals that we need to be focusing on to try to prevent us from moving on to type 2 diabetes. Okay, question came up before about impaired glucose tolerance and impaired fasting glucose. Well, this is a study in Japan, not far away, which shows cumulative cardiovascular survival. If you have normal glucose tolerance, you do pretty well. If you have impaired glucose tolerance, though, you're fairly close to having the same cardiovascular survival as diabetic. Whereas in this study, if you just had elevated fasting glucoses, you were closer to being normal in terms of your survival. So in this particular study, impaired fasting glucose was more of a cardiovascular risk factor than impaired fasting glucose. Here's cardiovascular mortality and impaired glucose tolerance versus diabetics. You can see there's essentially no difference. If you look at it in normal glucose tolerance versus impaired glucose tolerance, well, in females and in this study in Sweden, there was clearly statistically significant more mortality in impaired glucose tolerance versus normal glucose tolerance. What are ways that we can impact? What are some of these modifiable risk factors that I talked about before? Well, here's a study, the West of Scotland study, WASCOPS, using pravastatin. See, it took about 3 years, but there is a reduction in patients who were on pravastatin in their survival. Whereas in the diabetics, it took longer, but we also saw an even bigger improvement in survival. If you looked at the simvastatin Scandinavian survival study, the 4S study, you see that impact was seen earlier with simvastatin. Maybe it's again a little bit later, but you see a widely significant change. But even on the simvastatin, the mortality at the end of the study is pretty close to where it was in the normal individuals who were not on simvastatin. So this is data that suggests that LDL cholesterol is a magnifier, particularly in patients with diabetes, and why we like to get the LDL cholesterol in diabetics probably less than 80. A lot of people want to get it less than that. How much tight control is necessary? This is a very important issue because a lot of people come in and say, I want my sugar to be normal. Well, remember what we talked about high hypoglycemic strategies. What would you think about? Do we really want to risk the high hypoglycemic strategies? First, let's talk about what we really learned from A1Cs. It's not just how good your blood sugar has been over the past 3 months. This is a protein that's sitting inside a protective environment, inside the red blood cells, exposed to glucose, and glucose sticks to it. So just as glucose sticks to this protein sitting inside the red cell, so it sticks to every protein everywhere else in the vasculature. So it gives you an idea of the major way that the microvascular complications ensue. And looking at your A1C then is an index, a picture, right into the microcirculation. Well, how does it correlate? These are roughly the correlations. About every 31% is about 30 milligrams per deciliter of glucose. If you're averaging a 150, you're about 7, 360 at about 14. Okay, just as I said before, it correlates with the pathophysiologic glycosylation, the glucose stickiness, protein in the vasculature, correlates with small vessel complications. We really need to get to a target of 7, not less. It correlates with the lifespan of the red cell and therefore dependent on the normal. That's why we use 3 months as our time duration span for getting these A1Cs. Okay, what are the microvascular? We talked about the kidney as one of the most important organs, but this is the kidneys shrink, and you get this proteinaceous material. It's called diabetic Kimmerer-Wilson disease, glomerulosclerosis. This is a lesion that's pathognomonic of individuals who come in with significant protein in the urine, significant nephrotic syndrome and renal failure. What's a normal fundus looks like? This is what normal eye grounds should look like. In patients who have increased glycosylation, you start to see these exudates and little hemorrhages. And then when you start to see what's called this neoved, these new blood vessels beginning to form in these areas alluded to by the arrows, that's when you need laser therapy to try to prevent blindness. Here's a plot of diabetic complications: retinopathy, nephropathy, neuropathy, microalbuminuria. You can see there, all looks like there's this smooth increase. And as your sugars go up, there's a smooth increase in your risk for microvascular complications. But if you actually dig down and look at the data from which those curves were derived, most of them were derived from this particular slide from the DCCT trial, which was done in the 80s and 90s in type 1 diabetes. But if you look at this, what do you see? Well, these are deciles. These are all the patients throughout the trial. These are those in the lowest decile, the lowest 10%. You see that whether you were 6 or 6.5, you really were essentially normal. Whereas in order to get, this is eye ground changes, 2-step changes in the eyes, whether you were at 7 or 8 really didn't matter. You had about the same level of 2-step changes. Some higher, some lower, but all about the same in that range. And it wasn't really until you got way above 9 in that highest decile, this is where all the power was, to show all the impact of type. It's because of this data and because of this point that we now tightly control individuals with type 1 diabetes, because we know that tight control can reduce the microvascular complications, but it's only in this group. So how high do we have to? Do we have to get it down to 6 or 6.5? When you look at this particular data, I think if you look at it critically, there's good arguments, and there's other studies as well, looking at proteinuria coming out of Mass General, a fellow by the name of Anders Kolevsky, who shows that you don't go on to kidney failure until your A1C is above 9.1. And the Joslin Clinic also has those kinds of data. So it's getting above 9. So if we target people to 7 to 8 range, we're doing okay. They don't have to be normal. We're not going to get that. We're not going to cure the macrovascular disease. In terms of the microvascular disease, we're going to get all the bang for the buck that we need just by keeping them less than 8, or targeting 7. Okay, so now what kind of strategy should we use? Well, before we get into that, let's talk about insulin resistance and how insulin resistance may develop and how it relates to things like overeating. This study by Stephanie Coleman, she showed that insulin resistance can be associated with specific areas of the brain. And those individuals who have high levels of adipose in the belly, in the stomach, particularly vulnerable to hypothalamic insulin resistance and an altered homeostatic set point. Whereas if they had peripheral insulin resistance in the fat and muscle cells, that was linked to insulin resistance of the prefrontal cortex. And people with peripheral insulin resistance and the prefrontal insulin resistance had difficulties with food cravings and control over their eating. It's not something you otherwise might not have known. Here's a study that was done, published in the Journal of Clinical Endocrinology and Metabolism, but looking at the amount of cortisol, which is the stress hormone that's in your hair. And what they found was, and they looked at people and they did surveys: how much heart disease, how much strokes, how much other disease do you have, cancer, lung disease. They found that compared with those in the lowest quarter of cortisol, the lowest quartile, those in the highest quartile had 3 times the risk for cardiovascular disease and diabetes. So just by having elevated cortisol levels, stress hormones, which we know are controlled by the pituitary and the hypothalamus, can increase your risk for heart disease, macrovascular disease. These are studies that were done at Princeton and looking at sugar dependency. There's something, and there was release of opioids and dopamine in response to feeding these rats high sugar diets.